के साथ तो उस लिहाज से कि small pelvis, maternal age above 30, hypertension, previous cesarean section, bad obstetrical history, intrauterine growth retardation उसको कहते थे, got prolonged first stage, previous cervical tear, bicoronary uterus, purpose hospitalization वगैरह वगैरह. तो क्योंकि उस जमाने में ब्रीच हम डिलीवर करते थे, वो कंट्राइंडिकेशन नहीं थी, ये फिर मुख्तलिफ उसकी मैनूवर्स हैं, बर्न मार्शल टेक्निक है उसे हेड का डिलीवर करने की, ये है फोर्सेप्स सप्लाई, और फिर है डिले इन डिसेंट ऑफ ब्रीच, एक्सटेंडेड आर्म्स, लव सेट मैनूवर, डिफिकल्टी इन डिसेंट ऑफ द हेड, ये फिर किस तरह से लव सेट मैनूवर कैसे करनी है उसकी तस्वीरें. Why did I think of telling you about breech presentation when we do not do breech deliveries? Can you guess that? Because we generally now, whenever there is a pregnant woman who presents with breech presentation, then we very conveniently we opt for cesarean section, because there was this Danish study which told us that breech delivery, instead of breech delivery, if you deliver the baby by cesarean section, then the perinatal morbidity mortality is less. So, but you know, the author of this book, he belonged to a generation when cesarean section was not a safe option, because that 1978 edition was his last edition. Soon after that, he passed away. So he belonged to that generation when anesthesia was not so good, blood transfusion services were not so readily available. There were not so many antibiotics which were available to combat infection. But by the way, do you know when was the last antibiotic discovered or synthesized or made or introduced? Antibiotic class. When was that? 1980. 1980 के बाद कोई नया एंटीबायोटिक आया नहीं. जरा देखना, इसको भी फैक्ट चेक करो. इस ऐसी स्टेटमेंट जो होती है उसको फैक्ट चेक बोलते हैं. और कौन सा क्लास ऑफ एंटीबायोटिक्स आई थी? 12 So at that time breech delivery का था. तो के breech delivery का it has a special significance. Breech delivery. The reason for that is because the head comes afterwards. And now if you are aware of the mechanism of labor and the movements and the various positions which change, which occur during the passage of the head through the pelvis, then you would appreciate that all those maneuvers, usually in the normal sense, they are designed to put the smallest diameter of the fetal head through the pelvic cavity. Now, roughly speaking, pelvis has an inlet where the transverse diameter is larger. Roughly speaking, if you say 13 centimeter and anteroposterior diameter 11, 13.5 or 11.5. In the middle cavity, mid cavity, anteroposterior and transverse diameters are the same, about 12 centimeters. And in the outlet, the proportions of the inlet, they reverse. That is, the transverse diameter is smaller and anteroposterior diameter is the larger. So a head which comes into the pelvis like this, first the forces of labor and the resistance offered by the pelvic floor cause, and then gradually in the later weeks of pregnancy, what happens is that the attitude of flexion of the fetus that gradually increases because there is cramped space, there is less amount of fluid, and the shape of the uterus is such that the lower segment is comparatively narrower compared to the top of the fundus. So that is one of the reasons why head is there, because the buttocks make a larger mass compared to the head. So head finds its position conveniently because of that ovoid shape. Instead of the oblong, it is ovoid or whatever. So narrow, the lower part is narrower. So the head comes down there, and because of the pressure, that attitude of flexion further increases. So increased flexion of the head. And when it comes down into the pelvis, the resistance offered by the pelvic floor is that by which that attitude of flexion is further increased. And that brings the smallest diameter of the fetal head of an average fetus into the pelvis, which is about how much? 9.5 centimeter biparietal diameter, and submento vertical diameter also is the same, which is 9.5 centimeters. So 9.5 centimeter diameter is there, whereas in an average pelvis, the space available all around would be at least 11 centimeters. So it is generally not difficult for the head to pass through that. Now, similarly, because we know that the inlet is broader transversely and narrower. So the head comes down in a transverse direction, then it has to rotate through 1/4 of a circle to adopt the position suitable for delivery through the outlet in which the anteroposterior diameter is divided. That you understand. Now, when the head is coming afterwards, or what we call it the aftercoming head, then all that is not there. As a matter of fact, there is greater likelihood that the process of labor and any intervention in expediting the delivery that can lead to extension of the head, because the head is now coming afterwards, and if you pull it down, the head is likely to go, because there is no force which is pushing it down and accentuating or aggravating or adding to that attitude of flexion. So therefore, that extended head would throw a larger diameter across the pelvis, and therefore there will be likelihood of the head getting stuck in the pelvis. And if it gets stuck in the pelvis when it's a cephalic presentation, what happens? It is obstructed labor or delayed second stage, and then you can always opt for cesarean section. No damage done. But if it is an aftercoming head and that gets stuck, then it's disaster, because now there is no way of pushing the baby up, delivering through cesarean section, or pulling it down. So therefore, the importance of assessment and also awareness about the techniques by which you can reduce trauma, or you can prevent as far as possible the situations where the head extension can be prevented. You can kind of do that. So therefore, first of all, the assessment, pre-assessment, that's essential. Day before yesterday, I attended a seminar in King Edward Medical University. It was about oncology and CS cervix, because this is January is the month for prevention of CS cervix, or creating awareness about CS cervix, its screening, etc. But there was interestingly a talk by an anesthetist also about the various necessary investigations and workup for the patient from the anesthetist point of view. And what he said was important, that pre-op assessment of the patient and pre-op preparation goes a long way in minimizing or reducing the chances of complication during operation as well as in the post-operative period. For example, if you have a gross example is if you have a patient of placenta accreta, in which you know that there will be torrential hemorrhage. If you are not prepared with adequate saved cross-match blood units, then you are careless. Then the chances of mortality would be higher. And therefore, we always prepare patients in a fashion. One of the preparations is that we have adequate supply of cross-match blood. So that pre-op preparation is essential. Similarly, for breech, it is important that if it is to be delivered vaginally, that you carry out that complete assessment about the size of the baby, about the capacity in the pelvis, about other factors which ought to be ruled out, and only after having ensured that everything is appropriate, then you go ahead. And then, of course, you also must possess the necessary skill set to carry out the breech delivery. Now, why I thought of presenting it to you is the day before yesterday, I was performing a cesarean section in twins, and there was the baby who was to be delivered by Breech. But what I did was that for the second, it could have come out as Breech, but my attempt was to convert it into a cephalic. So I passed my hand in and caught hold of the head and brought it down and delivered it with forceps, etc. Even during cesarean section, I would rather not deliver the baby by Breech. But when we do cesarean section for Breech presentation, then you do a Breech delivery at the time of cesarean section on the operating table. It is Breech delivery. Instead of now, what happens is that instead of coming the aftercoming head coming through that bony pelvis, it is going to come out of that incision in the uterus. And that incision, of course, has the potential of getting expanded. It can expand, it can lead to lateral wall tears or downward tears, etc. That's a different matter. But at least the head will not get stuck behind. And one is not worried about its being fully flexed or being extended. So even if it is extended, but the same techniques which are employed when you are delivering a baby by vaginally as Breech, the same techniques are required at that time when you are delivering the baby at the time of cesarean section for extended arms, for the aftercoming head, because if you take longer, the baby will suffer from hypoxia or injury as well if you are not careful about manipulating the head and bringing it out. So you have to be gentle, you have to be careful, you have to be reasonably expeditious so that you do not delay the delivery of the head. So that's why I thought that I will at least familiarize you with some of the maneuvers, some of the methods by which the problems which actually come in and how we tackle them, right?
Question. Sir, if the aftercoming head is stuck, death is inevitable, then the baby dies. There's nothing.
What will happen? आप बताएं क्या कर सकते हैं?
सर अगर हम सिजेरियन भी करते हैं तो फिर भी ऊपर नहीं जाएगा तो फिर कैसे लगेगी क्या करते हैं बाहर
मैं उसकी तरफ नहीं जाऊंगा those body details वो अलग से है but of course अगर वो head stuck हो जाता है तो वो मसला है ना वो उसका कोई तरीका नहीं है उसकी तरफ तो चलो बाद में हम बात कर लेंगे लेकिन the point to be emphasized is that the head can get stuck if the pelvis is not assessed or the size of the fetal head is not assessed, etc., or if there is some other block. Now, if we look at the pelvis, one is you should know what are different types of breech. Breech is when the baby presents by buttocks. By presentation means presentation is the part which is presenting over the pelvic brim. That is presentation. So buttocks, when buttocks present there, then it is breech. And this is one. This, you should know that. And this is the other, and this is the third one. So there are three types of breech presentations. Generally, it is this or the flex breech. Which one is more likely to succeed in case of सवाल लिखो जिनके जवाब जाके तुमने किताबों में ढूंढने which are likely to succeed in external cephalic version, extended or flex breech? ये सोचना फिर उसकी वजह भी बताओ. अच्छा, अब now let's get on with the breech delivery. Now here it is the bitrochanteric diameter. Femur bitrochanteric diameter, which again is not large, and the advantage in this case is that buttocks are a little compressible because of the soft tissue involved, and that's why we take into consideration the bitrochanteric diameter. जरा उसकी भी मुझे measurement बताना कि कितना होता है bitrochanteric diameter. Now, when it comes down like this, बच्चा मुस्कुराता है. Some of the guiding principles, or especially sayings, which govern good practice of practical obstetrics. What is that? One of those. Can you name it? Can you phrase it? Patience. Patience.
So Breech to hostile inactivity.
Patience and the hands-off policy. Incidentally, वो भी मैं आपको बता दूं कि patience in also in cephalic deliveries. Please, all of you must exercise. We do not. As soon as the patient is fully dilated, do not put the patient in lithotomy. Please do not do that. Until and unless the head comes down onto the pelvic floor, do not do that. And in case of priming gravida, till it shows at the introitus. When the head shows, only then put the patient in lithotomy. In multiples, of course, if it comes down +2, then you can put it. Put the patient to lithotomy position if that is the position that we are going to deliver the patient in. But otherwise, don't do it. And if there is no indication as such, full dilatation does not mean that to start asking the patient to bear down and push down. It is not. It will take a little while. The uterine forces, the uterine contractions, they will push the baby down. When the baby's head is at the pelvic brim, it presses the pelvic brim at the height of a contraction. The patient will have a reflex desire to bear down. So that is the time when you can ask the patient to bear down in a gentle fashion. You don't have to cry it loud onto her. And not all of the persons present in the labor room have to shout at her, bear down, zor lagaएं, zor lagaएं. So वो किसी ने सही कहा कि some of the enthusiastic support in the delivery room, they ask so vociferously, so loudly that the patient, if not the patient, at least some of the sympathetic bystanders may have uterogenital. So therefore, that enthusiasm should be a little tempered. वो उसके साथ उस तरह से और जोर उस वक्त लगवाना है जब वो आ जाए, उस वक्त भी आराम से. वो सिर्फ अगर जब जोर लगाने की बात आती है तो एक ही नाम जहन में आता है. लेकिन वो एग्जांपल नहीं, उसको कर दे जो करती है. लेकिन तुम लोगों ने बड़ा आराम से, तुमने देखा होगा मैं जब करता हूँ तो मैं लोगों को नहीं करता हूँ, खैर वो एक बंदा ही काफी है, वो बताता है उनको कि हाँ जी आप टाइम है, अब जरा आप लोगों को लगाना सांस, वो ये बताते नहीं कि जैसे करना. खैर कम बैक ब्रीच. तो इसमें जो मास्टरली इनएक्टिविटी वाली बात आपने कही तो पढ़ के आई हो, इसका मतलब है ठीक है कि उसमें होना चाहिए मास्टरली इनएक्टिविटी. और दूसरी चीज वो है पेशेंस. पेशेंस जो है वो चाहे आप वो ये भी नहीं है कि उधर से डिप आ गई है बिल्कुल तो और आप फिर भी पेशेंस से बैठे हुए हैं, वो नहीं है. पेशेंस का मतलब है व्हेन एवरीथिंग इज गोइंग नॉर्मली लेट इट प्रोसीड नॉर्मली. तो वो उसमें अननेसेसरी इंटरवेंशन ना करो. वो फिर जल्दी बुरा आदमी फिर आ गया, अच्छा जी आ गया, लगाओ जी वेंटूल लगा दो, ये कर दो, वो कर दो, विद ऑल दी दोस कॉन्सिक्वेंसेस व्हिच यू आर क्वेश्चनिंग. तो ये जब आ रहा है ब्रीच तो इसको आने दो. It should be on its own. जी अस्सलाम वालेकुम. ठीक ठाक. हाँ जी, वो आपके डॉक्यूमेंट्स पड़े हुए हैं उधर हमारे रिसेप्शन पे, तो वहां से ले लीजिएगा हॉस्पिटल की. ठीक है, मेन रिसेप्शन पे. थैंक्स. ओके. सो आप इसको ब्रीच है कॉन्ट्रैक्शन के साथ, विद एवरी कॉन्ट्रैक्शन द बटक्स वुड कीप कमिंग डाउन, कम डाउन. ये पहले उधर भी दिखा ले तो फिर मैं इधर भी दिखा देता हूँ. तो ये नीचे 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 इस तरह से. अब इसमें what is the time to put the patient in lithotomy position?
When the buttocks are, that is not.
When you see the posterior buttock climbing the perineum, ये वाला time है जो जिस तरह से मैं अब वो cephalic presentation में बात कर रहा था, when you see that the posterior buttock is stretching the perineum and that is the time to put the patient in lithotomy position, right? So because this session is focused on some of the maneuvers, that's why I have not gone into assessment, etc. तो हम उस पे इसको रखते हैं. So वो और patient lithotomy में, and then what do? You sit back, you watch, you are scrubbed up, you are gloved down, and then you just sit there and you wait. So you wait. मैं वैसे दूसरी साइड पे बैठूं. So wait. When it stretches the perineum and it is time, then you do an episiotomy. After episiotomy, what do? Then again sit back, let it come down. You are to intervene only if you find that a group of cord is coming out. Then of course that becomes an emergency, and then you would go around. Or when it comes down to this, what you can do is you can flip a leg, you pass in two fingers, with 2 fingers, 1 finger in the behind the knee, and then you bring down the foot down. So you flex. If it is extended breech, you pass down the finger and then flip down. अब मुझे left hand इस्तेमाल करना पड़ रहा है, इसलिए so you bring down the finger, फिर उसको छोड़ दो, फिर आने दो. अब now what happens is usually the baby is in the fetus is in a flexed position when its arms are folded like this in front, or legs be folded होती है. Arms इस तरह से folded है. So if the uterus is pushing it down like this, the arms come folded in front of the chest down into the pelvis. But if you pull the baby down, अब यहाँ पे एक temptation होती है कि बच्चे को पकड़ के खींच लो. अगर आप ये करोगे, तो what will happen? Then the elbows they'll get stuck against the pelvic brim, and they वो arm ऊपर चला जाए. Now when the arms go up, then the mass of the arms also
Adds to the diameter.
it adds to the mass of the head. तो वो ज्यादा हो जाता है, right? So therefore उसको pull करके हम नीचे नहीं देखते. और उसके साथ फिर ये क्योंकि इसको आने दे, अगर यहाँ पे है, आप देख रहे हो कि arms हैं, तो you can flip out the arms as well like this, उस तरह से. और दूसरा है जब flip out हो जाएंगी arms इधर सामने, so when the legs are out there, you pass your hand over the ventral surface of the baby here and look for the arms and bring them down also, right? But if you can't find arms, then that is the maneuver that you will have to do. But first we will do with this. So you bring them down, and this is the time when your assistant should apply pressure in the suprapubic region. Yeah, when that pressure is applied, the head is forced into the pelvic cavity from there. So it comes into the pelvic cavity, and as it comes here, then it usually will be in a transverse diameter. So then there are 3 methods of delivering the aftercoming head. It still remains to be the largest hard mass, which is not compressible. So one is if the pelvis is too spacious and the fetus is small, the head will come down without much maneuvering. But if the head is like this, then there are 3. One is Bun Marshall. Bun Marshall there, that you let the fetus hang, the baby hang, on its own weight, and you can wait a little while. And during this time, of course, आपने इस दौरान में, if the cord length allows you, you pull a loop a little bit downwards so that it is not compressed against the fetal parts and the pelvic side walls. So when it comes down, let it come here for a little while, and then you can deliver it. Catch hold of the feet like this, and with this hand supporting the perineum, then you deliver the baby. You take it upwards and allow the fetal head to come out like this. Okay, this is Burn Marshall. You allow the fetus to hang baby. I keep on saying fetus because it is fetus still there. Now it is, most of it is out, it is baby. So you catch hold of that from here, bring it to horizontal level, and then upwards while supporting the head and the perineum, and allow its gradual birth or delivery. This is Burn Marshall. The second is the assistant holds the baby's legs and body in a straight line upwards, and you apply outlet forceps from below here, and outlet forceps, and deliver by outlet forceps like this. Right now, one of the dangers in aftercoming head is that if it is delivered suddenly, then there is possibility of from its entry into the pelvic cavity, which is sudden compression and sudden decompression, and that can result in intracranial hemorrhage. So therefore, delivery by aftercoming head, the delivery of aftercoming head with the forceps is something to be recommended for, and that is generally considered to be the best method, the safest method for delivery for the fetal head. So Burn Marshall, and then
So, sir, I can't get this now. How is it?
वो उसके बाद फिर दूसरा है forceps. ठीक है, तीसरा एक मेथड है, उसको बोलते हैं शोल्डर जॉ ट्रैक्शन, या वाई 3 लोगों के नाम से है, मॉरिसियो स्मेली वीट मैनूवर. मॉरिसियो स्मेली वीट था, मॉरिसियो एंड वीट. वो मैनूवर, in that you pass in a hand along the ventral surface, you place the middle finger in the mouth of the baby, and the index and ring finger on the upper jaw, on the, इसको क्या बोलते हैं, हाँ, इधर, और दूसरा हाथ जो है उससे 2 fingers on one side of the neck and 2 fingers on the other. Now, with the purpose is, with this you apply pressure and you cause flexion of the head, and this also helps in further flexion, and with this you guidedly shoulder jaw traction or Mauritius Malleate maneuver. So this is the third one. Now what happens if the arms are extended up? Arms are extended up. What do you do then? Then no, you do something. You you catch hold of the baby's pelvis with a sponge. You take a sponge and wrap it around the baby's buttocks, hold it with both hands like this, and pull the baby a little downwards, backwards and downwards in the anatomical direction of the pelvis, and then rotate it so that the posterior shoulder becomes anterior. When you do that, this arm, this automatically comes here, and you can flip it out. And then you rotate it again through 180-degree circle like here, and flip out the other arm like this. And this is something which you have to often do at the time of cesarean section. So at the time of cesarean section, you catch hold of a leg and bring it down. And because you are not afraid of extension, you can always do that maneuver. And then usually you have to do it. So you catch hold of that, and you must have someone who have assisted me or others, and they have seen this breech delivery at the time of cesarean section. They must have seen that we rotated like this and bring one arm first and then second arm, and then, and generally again, at that time also, it is better even abdominally to deliver the baby by shoulder jaw traction, by holding that instead of pushing it out. You see, even at that time, it is dangerous because you can apply too much of pressure. You can rotate the baby a little too much on that side. It can be sometimes with a modified kind of Burn Marshall maneuver, kind of shoulder jaw traction, or even forceps at the time of cesarean section also. But we'll keep these three methods of delivery of the head for the normal, for vaginal delivery. So one is that you must have assessed the size of the baby, the size of the pelvis, and any contraindication to breech vaginal delivery. We are not discussing that at this time. We are only concentrating on the technique. And then the first stage management is as usual. You would rather not rupture the membranes earlier because of fear of prolapse of the cord. Right, because in this position, the possibility of prolapse of the cord, particularly if it is flexed breech. In extended breech, it is less, but in flexed breech or footling breech, the chances of cord prolapse are a little more. So you do not do that, and then also allow the bag of membranes to be a good dilator of the cervix, because it would disperse the pressure equally onto all sides, all around to the cervix. So as long as the membranes, until unless of course they rupture spontaneously, that's a different matter, but you do not do artificial rupture of the membranes. So you allow the breech to proceed, and second stage is again watchful, and then put the patient in lithotomy when the posterior buttock is seen to be riding the perineum, and then when it gets stuck there, it doesn't go back after the contraction passes off. Then you perform the episiotomy and let the buttocks and the rest of the body come down. You can flip out the extended legs if need be, and then care of the cord if that is required. Then let the body come down further a little bit. Look for the arms in front, flip them out, or if needed, carry out Olafson's maneuver and ask the assistant to push down for the head, and those three maneuvers for the delivery of the head. Now, this is something which you need to practice on the dummy here. And then whenever you get a chance of doing a cesarean section and you come across a breech presentation, so that is what you should be doing. And be gentle with all these maneuvers so that there is no undue stretch or pull on the neck because of vital nerves getting damaged in the case that you apply too much lateral kind of that thing, or you push too much or pull with a stronger force. So this is how you deliver breech. Any questions?
Assalamualaikum, sir. Assalamualaikum, sir.
हाँ जी
सर ये लैग डिलीवर करते वक्त सर आपके कैमरे में पिक्चर वो वीडियो आई नहीं है सही से, तो लैग की तरह फिंगर्स की पोजीशन बता दीजिए प्लीज, और प्रैग, व्हाट इज द प्रैग मैनूवर? अस्सलाम वालेकुम सर।
पहला सवाल क्या है आपका? लेग्स को, हाँ जी, लेग्स को ये
सर वो वीडियो में नहीं आ रही है, तो सामने करके आप से फिंगर्स की पोजीशन बता दीजिए।
फिंगर्स की पोजीशनिंग देखना चाहते हैं। हाँ, बीबी ऐसे पकड़ लेते हैं और जैसे
हाँ, ये अगर इसको अगर ऐसे देखें तो ऐसे है ना, तो ये इस तरह से गई है लेग में ऐसे, ये आप देख रहे हैं, ये
यस सर
अंदर गई और ये मैंने ऐसे किया, अंदर करके ऐसे कर दिया, ये
एंकल से पकड़ के,
ये लेग इधर है ना, इधर है लेग, सो मैंने दो फिंगर्स इधर की और ये ऐसे करके एंड देन आई ब्रिंग डाउन।
सर नी के आगे सर आपकी इंडेक्स फिंगर है, मिडिल फिंगर है?
वो आप इंडेक्स, मेरी मिडिल फिंगर जो इंडेक्स फिंगर है वो नी के पीछे है। इसको कौन सा फोसा बोलते हैं? पॉप्लिटियल फोसा। तो ये पॉप्लिटियल फोसा में ये है, और देन आई जेंटली पुल ऑन और एक्सर्ट प्रेशर विद द मिडिल फिंगर on the lower part of the tibia and then flip it down. ठीक है जी? और दूसरी मैनूवर
Thank
क्या
you,
है
sir.
वो मुझे उसका नाम नहीं आया.
सर प्रैग मैनूवर है, अगर बेबी का जो है
वो जाके मैं पढ़ूंगा, मैं
anterior-
पढ़ के नहीं आया आज.
ओके थैंक यू सर, कोई बात नहीं सर.
ठीक है. और जी
सर वो किसी ने पूछा सर प्लीज ब्रीच एक्सट्रैक्शन एंड असिस्टेंट ब्रीच में डिफरेंस बता दें.
हाँ
Assistant
ये you see every breech delivery should be assisted breech delivery ideally, and all these if you apply one of the maneuvers for delivery of the legs or arms, particularly arms, and after coming head, that is an assisted delivery. So it is better to have an assisted vaginal delivery than spontaneous delivery, and spontaneous delivery would be possible only with a premature small baby. Now breech extraction is when the whole of the fetus is inside the uterus and you pass your hand in and you catch hold of a foot or a leg and then bring it down, and that is breech extraction, because then the later parts of the movements would be assisted breech delivery. So what I do in that case is, अब मैं लेफ्ट हैंड से करूंगा इसको इस तरह से कि अंदर हाथ डाला और ये जैसा हम we many a times do at the time of cesarean section, if it is it is transverse lie, oblique lie है, तो cesarean section के time पे भी we pass in a finger, try to identify a foot. कई दफा वो आर्म निकल आती है, हैंड निकल आता है, उसको वापस डाल दें, catch hold of the leg of the baby और उसको आप लाके उसको ऐसे पुल करते हैं तो दूसरी भी आ जाती है और इस तरह से करेंगे. Now इसकी इंडिकेशन क्या है in this? This is usually done, breech extraction, in case of second twin, for example. Epidural अगर patient को लगा हुआ है, पहला twin deliver हो गया है, second is found to be not breech है तो breech आने दोगे, but transverse lie है, ठीक? Transverse lie और membrane rupture हो गई, cord prolapse हो गई. That is the indication. Because twins में what happens after you have delivered one, the first twin, the second twin, what do you do then? You then you palpate the abdomen and identify the position of the and the lie of the fetus, second twin, and its presentation, etc. अगर खुद से पता ना चल रहा हो तो अल्ट्रासाउंड अगर अवेलेबल हो तो वो लगा के देख लो कि क्या है. And if needed, you do external version, ताकि अगर ट्रांसवर्स में है तो उसको आप longitudinal ले आओ, and if possible तो उसको कफेलिक एक्सटर्नल कफेलिक वर्जन करो, और अगर वो नहीं हो रही तो एक्सटर्नल पोडेलिक वर्जन उसको बोलते हैं, जिसमें आप ब्रीच उसको कर लोगे. तो ब्रीच भी आ गई, और उसको अगर ब्रीच हो गया है तो फिर उसको स्पॉन्टेनियसली आने दो और वो करो असिस्टेड ब्रीच डिलीवरी. लेकिन अगर मेम्ब्रेन्स रप्चर हो गई हैं, कॉर्ड प्रोलैप्स हो गया है और इट इज ट्रांसवर्स पोजीशन, तो फिर क्या करोगे? फिर ब्रीच एक्सट्रैक्शन करोगे. सो ब्रीच एक्सट्रैक्शन के लिए आप वो हाथ अंदर डाल के, और जिस तरह से प्लेसेंटा मैनुअल प्लेसेंटल रिमूवल के लिए आप हाथ अंदर डालते हो, तो यू पास इन योर हैंड, कैच होल्ड ऑफ अ लेग, आइडेंटिफाई दैट इट इज अ लेग, एंड कैच होल्ड ऑफ द लेग एंड पुल इट डाउन. And appropriately you can, then you develop your own method. Don't be in a rush, don't get too excited or too nervous about this. Keep your hand on the abdomen also and guide the baby with the both hands, one on the abdomen, which is kind of stabilizing it, and by the other you are pulling on the leg of the baby, bringing down one leg, and the other leg usually follows all by itself. But if it still is stuck, only with digital manipulation you bring it down. So this is how you do it for the second one, and that would be known as breech extraction. But remember, breech extraction is only catching hold of the foot and bringing it down, and the rest of it would be, of course, assisted breech delivery. So assisted breech delivery is a part of breech extraction. पहले when I started my training, तो उस वक्त डॉक्टर आशा ने मुझे सजेस्ट किया कि एक स्टडी करें, क्योंकि वहां उस वक्त नेग्लेक्टेड ट्रांसवर्स लाई और वो वाले काफी आते थे. आईयूडी हुई भी है, तो आईयूडी हो गई, नेग्लेक्टेड ट्रांसवर्स लाई है, उसमें हमने ब्रीच एक्सट्रैक्शन की. बट मॉडर्न ऑब्स्टेटिक्स, एक तो ये है कि उस तरह का पेशेंट आएगी नहीं आपके पास. नंबर 2, अगर आए भी तो इट इज प्रेफरेबल टू डू अ सिजेरियन सेक्शन इंस्टेड ऑफ डूइंग breech extraction in those patients, because at that time there is sepsis, there is likelihood of rupture of the uterus. So वो उसमें ज़्यादा हो जाता है. So actually, breech extractions indication is only in modern obstetrics for the second twin, transverse lie, ruptured membranes, cord prolapse. जी, और any other questions?
Compression or decompression.
Who can
ये भी आपने बता
please breach
ये
extraction?
भी आपने बता
हाँ जी, हाँ जी, और क्या पूछे, आप क्या पूछ रहे थे?
जो compression और फिर decompression होती है, आप कहते हैं कि
हंड्रेड
हाँ, वो कंप्रेशन जो यहाँ पे हुआ ना, वो कंप्रेशन इस तरह से कंप्रेशन ऐसे हुआ, ये जब इसमें से सॉफ्ट टिश्यू में से गुजरता है, ठीक है, वो आया कंप्रेशन, एंड देयर इज सडनली रिलीज ऑफ दैट कंप्रेशन व्हेन द बेबीज हेड इज डिलीवर्ड.
सिर्फ फोर्सेप्स से कैसे नहीं होगा, मतलब
फोर्सेप्स जो है, फोर्सेप्स उसको, फोर्सेप्स प्रोवाइड्स अ प्रोटेक्टिव केज, वो सडन कंप्रेशन नहीं उस पे हो रहा, वो डीकम्प्रेशन तो सडनली एक किस्म का होगा, बट सडन कंप्रेशन नहीं हो रहा. जब आप ऊपर से पुश करके और इधर से खींच के करते हो तो बेबीज हेड गेट्स कंप्रेस्ड, उसको वो होता है, और जब निकलता है एकदम से तो वो सडन डीकम्प्रेशन. तो फोर्सेप्स का वो है कि वो उसको वो एक
preventive coverage.
प्रोटेक्टिव कवरेज हो. Dursons and Chien. मैंने वो आई वाज टेम्प्टेड टू डू अ कपल ऑफ टाइम्स, वो किए तो नहीं है लेकिन मेरे से वैसे इनएडवर्टेंटली हो गया था, तो सर्वाइकल टेयर हो गया. ये पेशेंट मैंने वो डिलीवर की थी ट्विंस वाली, मेरा ख्याल है 2 तारीख को की है. पेशेंट का नाम मुझे पता है, मैं बोलूंगा नहीं अभी, रिमेम्बर?
नहीं सर, मैंने बाद में देखी थी वो पेशेंट।
हाँ,
Delivery पे
वो
नहीं।
कल ही मुझे दिखा के गई, दोबारा मैंने उसको क्लिनिक में देखा, तो मैंने उसका वो किया था, उसको देखा तो सेकंड वन वाज, तो मुझे अर्जेंसी क्या थी उसमें उसको डिलीवर करने की, थी कोई, थी कोई, हाँ, कौन, कोई आप में से था कोई, मुझे नहीं पता, ये है, लेकिन मैंने उसको वो उसकी ब्रीच एक्सट्रैक्शन की थी, और ब्रीच एक्सट्रैक्शन करके तो फिर उसको हो गया पीपीएच. जब पीपीएच के लिए देखा तो उसका लेफ्ट लैटरल सर्वाइकल टियर था, वो जो मेरे जरा ओवर एंथुसियास्टिक, इवन एट दिस स्टेज ओवर एंथुसियास्टिक अप्रोच नहीं किया था, व्हिच आई हैड टू स्टिच.
स्टक हो जाए हेड तो क्या करें?
कुछ नहीं फिर कर सकते, फिर मैं फिर वो बच्चा फौत हो जाएगा.
निकालेंगे कैसे, डिकैपिटेट करना पड़ता है ऊपर से?
मैंने बहुत कुछ बड़े सारे प्रोसीजर किए हैं, जो आजकल वो है ना म्यूजियम पीसेस है. एक सिम्पसन्स परफोरेटर कहा जाता है. सिम्पसन परफोरेटर आमतौर पे वी यूज्ड फॉर हाइड्रोकेफेलिक फीटसेस. वो ब्रीच डिलीवरी के साथ वो आ जाते तो वो बेहतर होता था. ब्रीच डिलीवरी आ गई है तो उसके 2 तरीके होते हैं, टू ड्रेन सीएसएफ एंड रिड्यूस द मास ऑफ द हेड. वो या तो ये है कि आप ड्यूरल पंक्चर कर देते हो, उधर से स्पाइन में कर देते हो, या हम ये करते थे कि उसका पोस्टीरियरली ले जाके, वो सिम्पसन परफोरेटर एक चीज होती है, उसको ले जाके फोरामन मैग्नम में उसको धकेल के उसको खोलते हैं तो वो सुराख बन जाता है, उससे वो फ्लूइड भी और वो आ जाता है. जो ऑब्स्ट्रक्टेड लेबर होती थी उसमें एक होता था, एक उसको बोलते हैं केफेलोट्राइप और क्रेनियोक्लास्ट. वो क्रेनियोक्लास्ट और केफेलोट्राइप मैंने वो इस्तेमाल किए हैं. वो उसमें से एक इंस्ट्रूमेंट होता है, वो फोरामन मैग्नम से स्कल में चला जाता है, और 2 उसके इस तरह से होते हैं जो बाहर से जाते हैं, वो उसको टाइट करते हैं तो वो कोलैप्स कर जाता है, और उसके साथ फिर वो हेड का मास जो है वो रिड्यूस हो जाता है. क्रेनियोटमी तो हो गई ना, क्रेनियोटमी तो होगी जब आप उसमें से वो करते हो, तो वो मैं तुम्हें दिखा देता हूँ, लेकिन मैंने एक से ज्यादा दफा इस्तेमाल किए हैं क्रेनियोक्लास्ट एंड केफेलोट्राइप.
वैसे मतलब सिजेरियन की जरूरत नहीं पड़ती
फायदा नहीं
नहीं,
है,
बेबी
बचा
बताई भी नहीं रहा।
है।
Cesarean कैसे? body नीचे head निकाल।
यही पूछना चाह रही थी ना कि कैसे निकालते हैं.
क्रेनियोक्लास्ट
हाँ, decapitated.
डीकैपिटेट करके भी तो सर को बाहर निकालना ना, डीकैपिटेशन करनी ना होती है उससे.
Sir, footling breech पूछा।
है इसमें तस्वीरें कहीं से मैं दिखा दूंगा तुम्हें। हाँ।
Sir, मैं नेट पे
हेलो, हाँ मैं बस 5 मिनट में आ रहा हूँ। हाँ, ओके।
सर फुटलिंग ब्रीच इन लेबर की
हाँ करा लो।
सर एक और सवाल
हाँ।
कह रही है सर फुटलिंग ब्रीच इन लेबर की मैनेजमेंट बताएं।
Footling breach में the again in that there are two things. One is that cord prolapse again would be more common, even more common than in flex breech, because there is one foot dangling already and there is not enough of the fetal parts to prevent back the prolapse of cord. So that is one. Second disadvantage of that is, or that can be the first disadvantage, that since there is 1 foot downwards, there is no definitive mass as such which would be a good dilator of the cervix. You see, the cervix does dilate on its own. It is because of the bipolarity of the uterus, because the uterus contracts from the cornwall and the contraction starts from there and spreads down. But the effect on the lower part of the or lower segment of the uterus is this, that lower segment gets stretched. तो वो that, and because of that वो contraction retraction होती है, contraction के बाद relaxation से वो नहीं होता, थोड़ी सी retraction भी होती है, because of which the body wall of the uterus that becomes gradually thicker and thicker with passage of labor with every contraction, because it doesn't go back, the myometrial fiber doesn't go back to its original length, it remains a little contracted. But the lower pole that gets stretched, and because of stretching that also gets thinned out. So it opens up, it gets stretched, it's all that. It will eventually open up. But if there is head which is pushing against it, that's kind of a mechanical factor which is causing the cervix to dilate further, not only on its own, but also by push of the head. In case of breech also, there is that mass of the buttocks which again pushes it like that, and I made a reference to intake membranes, that they would be there as such, distributing pressure all around the cervix for its dilation. But in case of footling breech, it is 1 foot, and you can imagine that it is not in good contact with this membranes as well as with the lower segment of the uterus. So dilatation of the cervix or its expansion, that would be compromised to one thing, and secondly, chances of cord prolapse would be more. But as it comes down, once the cervix is completely dilated and everything, then you allow the delivery to take place on its own, and you only touch the baby for the first time when the leg comes out. Even in normally, I kind of missed this particular sentence, that you make an episiotomy and allow the buttocks to deliver on their own, and when the buttocks and the body of the baby has been delivered up to umbilicus, only then you are for the first time allowed to touch the baby. Till the body, till the umbilicus comes, उससे पहले नहीं, उस तक आने दो उसको spontaneously. तो ये भी इस तरह से. ये वापस कर देना. अच्छा है ये.
तो फर्रुख,
हाँ जी.
डिलीवरी तो कंप्लीट कर ला क्यों?
वो पहले कर ली थी, ये दोबारा दिखाइए. मैं नाल देखो, मैं ईएन डोनल की किताब भी लिया के इन्होंने दिखा रहे हैं.
ये 10 के मैनू ते हिफज सी.
मैं बल्कि जेफ कोट दी वो मेरे को गुम हो गई सी 1975 ਦਾ एडिशन, ਤੇ ਉਹ ਮੈਂ ਉਹ ਸਪੈਸ਼ਲੀ ਮੰਗਵਾਈ ਹੈ ਕੈਨੇਡਾ ਤੋਂ, ਉਹ Amazon ਤੋਂ 1975 ਦਾ ਐਡੀਸ਼ਨ. ਇਟਸ ਅ ਪਲੇਅਰ ਰੀਡਿੰਗ ਇਟ.
हाँ वो तो